So, just by way of introduction, my name is Emer Shanley. I work in the community in West Cork in Ireland, and I also work with the College of Surgeons, so I try and have a foot in both camps. I have an interest in academia and research, but really I'm clinical. So it's lovely to be here today, and a huge thank you to Ellie and to all the trustees for inviting me to speak to you today. I hope I don't bore you senseless, but I'll try not to. So the title that I was given was Quality of Life and Wellbeing. Is there a difference? I'm not sure I answer the question. In fact, I don't, but I just want us to think about it. So just before we go any further, I'd just like you to have a look at this slide. And I think if we can keep this in our minds all the time when we're working with people, I think it'll start us off on the right track. So you're not your illness. You have an individual story to tell. You have a name, a history, a personality, but staying yourself is part of the battle. And I think as clinicians, we all see this all the time, that it becomes that all that's seen really is the leg ulcer or the wound. So we just need to try and redirect our thinking. So just to get a little bit of background, and I know you know all this all the time, but I just think it's always really important to go back to why it's such an important subject that we're dealing with and that we're working with all the time. So within Ireland, our population is ageing, much like Britain, and over the next 20 years, our over 65s are set to triple. And with this rise in the elderly population, obviously that's going to lead to a rise in chronic illness, things like heart failure, diabetes, mobility issues, which of course will have a direct influence on the development of chronic wounds. So we need adequate service planning, and that's essential if we're going to preempt the predicted healthcare demands of those affected by leg ulcers. If I could just bring some few managers from Ireland to sit here today and be inspired by what I've listened to all day, I wouldn't have to be beating this drum. Wound care in Ireland, and particularly in the community where I work, we don't have leg clubs, we don't have a social model. We have a two-tier system. So if you have a medical card, then you can avail of the HSC, which would be, very similar to the NHS. So you're entitled to your wound care and your products and visits from district nurses and all of that. If you don't have a medical card, which a lot of people don't, it all stops. You don't have any access to the services, or if you want to access, you pay, and then you pay for your products. And then you try and find a district nurse that won't mind the fact that you don't have a medical card and that they'll agree to treat you as well. So it's very, very challenging to try and deal with that and to get equity for everybody. And I would have a huge interest in the social model, so that's why this is a fantastic place for me to be here today. So hopefully going forward we will get a bit of work done around that, and I know there are rumblings around looking at things within Ireland, so hopefully we'll be coming back and telling you about a leg club at some stage in Ireland. So patient advocacy, of course, has to be a huge component of nursing care, and we all know that. So the impact of leg ulcers, obviously they're a significant healthcare issue, and they impact negatively on healthcare costs and a quality of life. In Ireland, the prevalence is noted as between 0.12 and over 1% in the over 65s, and that's pretty much equivalent to what you get in Europe and the USA, which is between 1 and 3% of the elderly population in Europe and the USA. And then from an economic perspective, the costs associated with leg ulceration are huge. And it was just a privilege to listen to Julian Guest this morning presenting his results. And I sat beside him at dinner last night trying to get, sneaky bits of information so that I could go back to Ireland with all the newest figures. But actually it is frightening to look at the costs going forward. But I think, I apologise for the picture, but I do think we talk a lot of theory and prevalence and incidence and throw words around, but I think it's really important to remind ourselves of the kind of wounds that people are dealing with and the impact that this can have on them. So this is quite a young man in his 50s, and the impact of these wounds, they had a huge impact on his life. He didn't want to engage with the services. He didn't have a medical card, but we got around that. He was embarrassed, he was overweight, his mobility was dreadful, so he stayed at home all the time. But then that caused a huge problem because his wife didn't really want him to be at home all the time because the wounds were, they were smelling, there was an awful lot of exudate, and the issues that this poor gentleman had to deal with were absolutely incredible. So as you can see, this would affect all activities of daily life, including both physical and social aspects. This man eventually became housebound. Now things have turned around since and things have improved for him, but this is when I met him first. So pain obviously is a constant problem, and I do think when we're talking about venous leg ulcers, we can sometimes underrate the effect of pain in leg ulcers. You know, this old school of thought that pain is really associated with arterial and not with venous leg ulcers. But any of us working clinically will know that pain is a huge factor that has to be addressed within wound care. And I've already spoken to you about the physical effects, including malodour, leakage of wound fluid, infection and itching. Then you take all those and you have all the emotional issues, including things like low mood and anger, frustration, which is a huge thing, anxiety, depression. And you know, when we talk about frustration and anxiety, we then as clinicians are on the receiving end of that because patients are frustrated, which is, we can't blame them a lot of the time. The psychological impact, including feelings of embarrassment, issues around body image and loss of confidence and self-esteem. I had a burn about 2 months ago, the most ridiculous thing that could possibly happen. Staying in a hotel, went to make a cup of coffee, picked up the kettle, brain still half asleep. The lid of the kettle was actually in the kettle, there wasn't a base, so picked up the cup of coffee to make a cup of coffee and poured a whole kettle of boiling water over my hand. Really painful. So this had pain, all these things that I've really learned all about at a first hand. I was actually even looking up Kate and Gary's Facebook page because they'd had a post on recently about how you treated wounds. So as I had my hand in a bucket of water, that's what I was doing. But to get around all of that, what was as you can see, it's fine, it's grand, it's not a bother. But I went around for quite a few weeks with coverage and, you know, sleeves down, hiding it, really embarrassed about the fact that I had a wound like it on my hand. And I'd have paid lip service before this to, you know, body image and feeling of embarrassment. I've lived it now, I get it, and look, it's grand, there's no scars, there's nothing. But what a learning curve for me. You know, getting my own dressing bag out of the car. My daughter was with me at the time, who would be exceptionally highly strung, but actually she's okay in a crisis, she did quite well, so we managed and all was fine. But I just think we just have to keep reminding ourselves of the impact of wounds on everybody. But one of the really important things is the patient's experience of the therapeutic relationship that they have with their healthcare professional, whoever that is. So that's going to be a recurring theme throughout all of this. Costs. I'm not going to go over it. Julian explained it perfectly this morning, and my figures obviously are, you know, old now compared to what Julian was talking about, but the costs are massive and the impact on the service delivery is huge. But we talk about patient involvement and we want to get our patients involved. So Chase in 2000, which sounds like such an old quote, but I just love this. She said that knowledge is the predecessor to self-management, particularly when you're living with a chronic condition such as leg ulceration. And I think it's a really true statement. Patients need to feel that their suffering can be eased by a sensitive collaboration, no matter how challenging they may be. And nurses need to establish and maintain a therapeutic relationship with their patients going forward. But patient involvement in healthcare and the rights of patients to have a central part to play in their healthcare process has for a long time been seen as an important aspect of healthcare provision. The benefits are believed to include enhanced motivation and knowledge about health and illness, and that then results in an increased ability to monitor and care for themselves. But why don't they comply with their treatment or get involved in their treatment, or what are the difficulties around it? A lot of the time it's to do with a lack of education about venous leg ulcers. And I know certainly in Ireland we don't have a lot of standardised patient education programmes, which is why that's what I'm working in now. But we bandy terms around like compression and chronic venous insufficiency, and we use all these terms, but do we actually explain what we're talking about, and do people understand what we're telling them? Then physical factors. So I don't know about you, but if I wasn't presenting here, I'd probably be outside with the industry partners trying on a new form of compression or a form of compression hosiery, and I'd have to stay in it then until I get home that night and wearing whatever shoes I had come to the conference in. And it's a fantastic, if you can get people to put compression on you when you're at a training day or an education day and you just can't change until you get home, it's a fantastic way of actually really understanding the impact of wearing compression. So then things like skin irritation, discomfort, difficulty with applying and removing compression hosiery. I've bought a few fancy gadgets for teaching for patients and for nurses where, you look at applying compression hosiery and removing it. And I made an awful mistake one day, brought a lovely new applicator with me up on stage like this. So now I'm going to show you this fantastic applicator for putting on elastic stockings. And I got stuck with my leg half out of stocking and half out on the stage, and everybody looked at me and I went, this just shows you it's just a lot more difficult than we think. So it's always worth trying them, and particularly before you go on stage. So then the appearance of bandages and hosiery, it does restrict our clothes and our footwear and showering. I had a gentleman with a diabetic foot ulcer who was, he needed to be offloaded, so he got a pair of custom-made, really expensive shoes that he waited for probably 4 months. And when he got them, he was devastated because he was a bit of a rock star. In his head, he was a rock star anyway, and he always dressed really well. He played music, he sang, but he loved winkle picker shoes. And he felt that he now had to go out, and he really wasn't dressed anymore because he couldn't wear the kind of footwear that he'd have liked to wear. So, we think this is, predominantly women that are really into their footwear, but he taught me otherwise. And then again, back to this, the poor relationship with healthcare teams. I'd love to say that this photograph is a very old one. It's not. It was sent to me lately by a clinician with somebody that turned up at their clinic, and this was the way the compression had been applied, and a patient turned up like this. And I think it's horrifying to think that somebody would be suffering like this. And this is where we talk about things like where you have clinician issues. It's not all patient issues. We have issues as clinicians as well that we really have to address. Things like poor assessment, and that was very well spoken about there before lunch. The inappropriate choice of therapy, and then incorrect application and lack of knowledge about treatment. So that's a little bit of background. But then when we talk about health, what is health? So the World Health Organization, they tell us it's a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. Quality of life? Well, they also define quality of life, but when the World Health Organization define it, they say it's an individual's perception of their position in life in the context of the culture and value systems in which they live and in relation to their goals, expectations, standards and concerns. So I just think that in all that statement, it's nothing about what our idea of quality of life is. It's about the individual themselves and what their standards are or what's important, not ours. How do we measure quality of life? There are tools out there. I'm going to fly through them because I know it's after lunch and you're probably all familiar, but there are quality of life tools out there and available, and they all bring their own things to the table. So the World Health Organization, they have an instrument, and that's organized in 6 broad domains of quality of life. And it talks about physical domain, psychological levels of independence, social relationships, environment, and spiritual domain. And then that produces scores relating to the particular facets of quality of life. The Cardiff wound impact question. I've never heard so much about Wales in all my life, other than when Ireland are talking about rugby. So we have the Cardiff, and that then looks at the overall quality of life, social life, well-being, and physical symptoms in daily living. Then this one is you're probably all familiar with this area. This was sent to us in the Tissue Viability Nurses Association in Ireland, and this is an assessment that's designed that you complete initially at the first assessment and then every 4 weeks afterwards, and it's designed for the patient to complete themselves. I really like this one. I think just the questions are very pertinent. The drawings are very good and very clear. I think it's a really nice document. Now, obviously, this is all part of their leg ulcer pathway, but I suppose the point of all of this, there are lots of tools out there and they are available, so just to see which one will actually meet your needs. So that is the rest of that. Wellbeing then, what's wellbeing? So the Department of Health in 2010 said it's a positive physical, social and mental state. It's not just the absence of pain, discomfort and incapacity. If you go into the Oxford Dictionary, it'll tell you it's the state of being comfortable, healthy or happy. The concept then of well-being is broad and has been debated since Aristotle's time, when he spoke about the contented state of feeling happy, healthy and prosperous. The chronic diseases centre. They say that at a minimum, well-being includes the presence of positive emotions and moods, such as contentment and happiness, the absence of negative emotions, such as depression and anxiety, satisfaction with life, fulfillment and positive functioning. So there are quite a lot of factors, aren't there, for us to think that, we have a sense of well-being. You need a lot of things to stack up within well-being. So if you put in a Google search and look at the words that are associated with well-being, as you can see, it gets broader and broader as we go on. But within public health, physical well-being, it has to be an essential component of overall well-being. Within research, then, studies have looked at many aspects of well-being, including physical, economic, social, developmental, etc. But people who enjoy high levels of well-being can be described as flourishing, and I think it's a lovely word. Now, obviously, on the other side, people who have lower levels of well-being can be described as languishing, but people who flourish will tend to flourish no matter what situation they are in. Flourishing describes feelings of happiness, contentment, curiosity, but also an ability to fully engage in what is happening around you. This is my favourite. Quality of life, it's directly related to just how lazy we can be without dying. That, to me, at times would sum up my life, but anyway. So simply put, well-being, it's not the opposite of ill-being. It's an overall assessment of a quality of life, but critically it's according to their own chosen criteria. So I'm just going to tell you about a lovely study that I looked at. Now, it's a TED Talk, so you can Google it and you'll find it. So this is one of the longest running studies that are out there into adult development. So it began in 1938, and what they did was they enrolled 724 men in two groups. One group attended Harvard, so they were in like first or second year in Harvard University. And the other group then came from one of the poorest and the most underprivileged areas of Boston. They were living in tenements. Things were exceptionally difficult for them. And what they did was they developed a questionnaire, and they looked at things like, about their work, their home life, their health. This was repeated regularly the whole way through, but as it went on, now this study has had 4 directors. It's still ongoing. Some of the men that were originally recruited onto the study are now in their 90s, and their wives and their children have now also been recruited onto the study. So, what did they find? What's this got to do with wound care? That's the other question. The clearest message was that if you have good relationships, it'll keep you happier and it'll keep you healthier. So social connection is really good for us, whereas loneliness kills. A recent study in America said that 1 in 5 American adults say they're lonely. Where I work in the community in Ireland, it's really rural, and I know that very often I'm the only person that people meet, or the nurses are the only people that they might meet from one end of the week to the other. And these are people who might have maybe 7 or 8 children, but everybody is busy and on the go and that. So people definitely are lonely. The study also found that people who were more socially connected, that could be to family, to friends, and to their community, they were happier, but they were also physically healthier. They lived longer than those people who were less well connected. And this study, their findings were that they feel that the experience of loneliness was toxic to a person's well-being. So all this is all the information that you all know, but I just think it's fantastic that you can look at all different types of studies and it'll all come back to the same thing, that this social model is so important, that the Lake Club is hugely involved in and is providing for a very long time, but you can go and look at research all around different things, it'll all come back to this. And I also think as practitioners, if we're going to be providing a really good service, we in ourselves have to be in a good place, and we need a good quality of life, we need a sense of well-being ourselves, and I think an awareness of all of that is really, really important. So, as I said, those who were less well connected, that's if they were lonely or if they were isolated, their health actually declined at an earlier age. Their brain function declined sooner and than those who were better connected within the study. But they also said it wasn't the number of relationships or close relationships, and this isn't even talking about a marriage or anything like that, but the good relationships that you have. So it's not the number, it's the quality, and it's ensuring that you're living in a good, warm relationship, and that in itself is protective. So I loved it. I don't know, I'd love to see what happens in another few years with the trial, but I don't think there's much more running in it. But as I just said to you, so this is lifted directly from the Lake Club website, so I'm not going to read it out, you all know it. But really what the Lake Club is doing is it's addressing social isolation, it's looking at a sense of well-being, quality of life, all of that, which is what we need, and this is the story I'll be taking back home as well. A study by Upton 2015 also reiterated that, and I'm sure you're all very familiar with this study, which says that the model of care offers huge advantages when presented with the challenges of providing holistic care to socially isolated people living with wounds. Self-management then is another key issue, and it forms an essential part of the chronic care model, which suggests that an informed patient who cooperates with a proactive team, it will result in better clinical outcomes. But patients also need to have easy access to relevant and understandable information if they're going to make informed decisions. And the European Patients Forum, they have a campaign for patient empowerment, and they put education right at the centre of one of its cornerstones. Self-management then, why is it so important? Research will tell you that for somebody living with a chronic illness, they'll spend approximately 3 hours a year with a health professional. So they'll manage their own health 8,757 hours. So I just think it's a real important statement, and to think of it, the amount of, for people who are lucky enough to attend a leg club, they're in an environment, but a lot of the patients that I have that are living with wounds, that is the reality of their life. They don't have contacts. Education then, I'm always pumping on about education. One of the strategies of the health service when you come to older people is that we want them to be enabled, we want them to live active and healthy lives, to participations in society, but also people need to be facilitated to stay at home in their own homes for as long as possible. And in order to do that, we have to get individuals involved in their own health, and to do that they need the knowledge, the skills and the attitudes to participate in their own health care. I recently developed a programme for patients who might be at risk of pressure ulcers, and it's like that, it's all about giving people the knowledge and the skills to get involved in their own health. And actually older people really loved being part of the education programme, so hopefully it's something we'll be able to roll out going further on. But what are you aiming to do? We talk about education, we talk about, there are words that are bandied around, but I think it's really important that you have clear aims when it comes to patient education. So you want to engage the patients to develop their competence in the skills necessary so that they can undertake the health behaviours, but also that those health behaviours are congruous with their life plans and underpin their independent decision making. And by doing that, you'll ensure that the patient is receiving an intervention that will ultimately improve their health-related quality of life by enabling them to make fully informed decisions about their health and well-being, and thereby increasing self-efficacy and self-management. So we ran a trial. There's an Australian program called the Leg Ulcer Prevention Program. I don't know if any of you are aware of it. A lady called Suzanne Kapp was presenting at a conference a UMA conference a few years ago, and she was talking about this leg ulcer prevention program. And I was sitting in the audience, and I went up to her afterwards, and I was like, I want to do a bit of study in Ireland. Is there any chance I could borrow your programme? Being really Irish with a thick neck, kind of going, should give it to me. Now that I've developed my own programme and I realise the amount of work that's in it, I'm really embarrassed about the fact that I just wandered up to her and asked her for it, but she gave it to me. And we did a trial in the community in West Cork. So what we had was quantitative research, usually a cluster randomised trial, but we also captured some qualitative data within it. So we had 64 clients, and they had attended leg club or leg clinics previously in the previous 12 months. And then each leg clinic was, I keep saying leg club because I'm hearing leg club all day, so sorry. I'm starting to call my own clinics a club now. So participants were either on an intervention or a control. If they were in the intervention, they got to do the programme. If they were in the control, they continued with their usual care. What did we find? Knowledge scores were statistically significantly improved, so people actually really learned. So the kind of thing, the information that they were given is what causes a leg ulcer? How can you prevent one from happening? How do you manage your skin? Things like that. They were encouraged to do leg exercises. This is usually the part of the day where when I see people falling asleep, when I talk about leg ulcers, I get them to stand up and do heel raises and squats. But you're so lovely and comfortable looking, I won't do it. But we got participants doing leg exercises and getting them to elevate, and skin care as well. So they all reported getting involved with skin care. It didn't make any impact on their nutrition. It's a big issue for us with older adults, and ensuring that they have appropriate nutrition. And poor fluid intake is also a big problem. But the participants loved the programme, and the older adults learned more consistently than the younger. So the participants in their late 80s were way better than the participants in their 50s with their results. But the kind of qualitative things that we got, I had one 75-year-old man who was on the programme, and he had had episodes of leg ulceration over the previous how many years, and he said that watching the programme, he felt that it was the first time that his suffering had been acknowledged. And what his words were actually, the computer sees what I've suffered. So he felt real validation that somebody out there understood the amount of pain that he had been going through. 2 participants loved the fact that they had got into a habit at home with their family and with carers coming in, where they were told that they needed to rest and they needed to pull up their legs. So if their leg wasn't improving, they felt it was their fault because they weren't resting enough. Of course, I come in then and I was like, sorry now ladies, up, out, half an hour walk every day. And they were delighted because they would have been active for a very long time, but I got such mixed messages that they had lost that ability along the way. People talked about feeling more empowered and feeling that they were more able to question what was happening. But another lady spoke about the impact of pain. And this was a lady who, until the leg ulcers were controlled and were managed, she had uncontrollable pain. She was crying at night. Somebody suggested to her that a hot whiskey might make her sleep. So she started at 80 odd years of age having a hot whiskey every night. She had never drank before this, but she said she felt it helped her get to sleep. So she went on the programme, she started getting into the appropriate compression, the pain improved, everything was going along very nicely, but she came in one day and she started crying. And I was like, what's wrong? I think I've developed a drink problem. I'm now waking every night and I think it's just for the whiskey. And I'm like, no, I think you're okay. 1 hot whiskey, you're all right, you're fine. But it was amazing the impact that had had on her. So that programme was fantastic, but unfortunately it's belonged to the Australians, so it's gone back to them there now. So we're going to look at developing another one, hopefully in Ireland. But a colleague of mine in the college has just completed a study on patients with lymphedema, and there was a lovely graph earlier on, and I wasn't fast enough to get the photograph where lymphedema is the tiny little dot on the outside. But she just did a lovely trial where she had 20 patients recruited for complex decongestive therapy. And what she found, so the protocol for the study, so for the first 4 weeks, people were seen 3 times a week. They had manual lymphatic drainage, they had skin care, and then they had their compression bandaging. At week 4, then they were measured for compression hosiery. So then the maintenance phase, there was a 60-minute therapy session twice a week for 4 weeks, and then they got their verbal and their written education on all aspects of self-care. And what she looked at was things like, changes in the limb volume, quality of life changes. She did interviews with people. And then they also kept a diary for 4 months. But within the interviews, so I've told you all of that. But what came out of the interviews was fascinating. What she found, the biggest theme to come out of it was the health professionals' lack of knowledge in the field of lymphedema. And this followed up another trial that was done about 10 years before this, where people living with lymphedema also felt that health professionals didn't have the knowledge or the skills to look after them. But I think in this day and age, that's an awful finding to have. Now, in Ireland, we don't have lymphedema services. There were a couple of clinics in the acute services. We've none really in the community. So it is a challenging thing to deal with. So I suppose, to be fair, the education hasn't been provided, but we have a lot of work to do on that. So like that, when I say that followed up on lots of other work that had been done, and these references might be old, but a lot of the things still run true. So expert found that the importance of assessing the patient's view of your healthcare professional. So we all, the whole way through life, very often we meet and work with people that we just don't click with and we just don't get on with. So we really have to make an effort to try and ensure that we do establish a really good working relationship with the people that we're working with. Participants said that staff who explained treatment options were viewed as caring, competent and skillful, and that this in itself gave patients a sense of security. Hopkins then looked at coping strategies for individuals that had non-healing leg ulcers, and they found that actually patients and professionals differed in what their understanding of concordance was. But Van Heck looked at processes underlying patient adherence to treatments for venous leg ulcers, and they found that the nurse was central to patients' adherence and recommended that nurses really need to be aware of the factors that promote adherence, such as outcome expectation and fear of recurrence. This is, I suppose, the parting note. I think, people living with leg ulcers and with wounds, they're juggling a myriad of challenges that are very often hidden from view or overshadowed by obvious physical signs. So we need to delve deeper. We need to serve our patients well. It's like the iceberg. The wound really is only just the tip of it, and it's all the other things that are going on that we really need to try and find time to address. So thank you very much for your time and your attention. That's it. Thank you.